Okay, so I'm going to start with the case of this 26-year-old woman. She has a history of quadriplegia, secondary traumatic C2 injury in 2016. She also had neurogenic bladder, neurogenic bowel, status quo diaphragmatic pacemaker. She has a history of left hemicolectomy after a very severe circular colitis with an endoscopy earlier last year. And she was basically admitted for infected decubitus ulcers that they were managing with like IV antibiotics. During the course of her admission, like a couple weeks since the admission, she started to present these recurrent episodes of non-bilious, non-bloody emesis. More than 10 episodes per day. She basically was unable to keep anything down, so poor PO tolerance. But they described no changes in the ostomy outputs. There was no documentation of like any decreased ostomy output. The patient reported abdominal distension, but she said she didn't have any significant pain. When they did the first KUV, basically they found this severe stomach dilation, which was measuring around like 15 centimeters with a transition point around the duodenum. They called us on a Saturday morning, basically for an endoscopic placement of an NG tube. That was the reason for the consult at that time. But then, you know, it's a Saturday morning. We had like a lot of like more emergent cases, actually endoscoping that day, later or something like that. So we told them we'll see the patient, like, you know, like we encourage the team to try to, you know, do multiple bedside attempts. They say they did at least 7 prior attempts at the bedside to place the tube, including surgery and ENT guided attempts, all of them failed. So we told them, okay, we're gonna go back to see the patient. Later that day, I got a call from the team and they told me actually the surgery resident came by and they were able to do the bedside placement of the NG tube. So, you know, no need to see the patient. Fine. When they did that, they basically gained around 5 liters of like greenish output, and this was the KV after the NG. So basically, we can see like how the mass is compressed. We still, you know, went to see the patient, especially because of this like significant stomach irritation. And this is an a CT that they got before the NG tube was placed. And as we can see here, there's severe dilatation of the stomach and the proximal duodenum down to a transition point in the distal second portion of the duodenum that they describe as compatible with duodenal obstruction. And the proximal duodenum was dilated to 5.1 centimeters. We also see a lot of like stool burden as well. So then, you know, given the concerns that she could have like some sort of like duodenal obstruction, we decided to proceed with an EGD a couple days after. And of note, the patient had 2 EGDs within a span of like a couple days. The first one was done by the advanced endoscopy team. This is not the one that they did, this is the one that I did with Satish. The first one, when they did it, they basically had to use the XP scope, but they had like pretty much similar findings. So initially they thought it was a foreign body, you know, in the esophagus, but then kind of like thinking more about what this could be, actually we realized this is the hardware from like her cervical spine surgery that was eroding into the posterior wall of the esophagus. These were my multiple attempts to try to intubate, you know, to kind of like pass that area, and I couldn't pass. I had to come kind of like in and out. The advanced endoscopy team, they actually were able to pass that area with the XP scope, and they found like a couple of ulcerations. But then I realized, and I'm gonna like try to pause this and go back. Basically, there were like 2 different lumens, one with the eroding, you know, like hardware, and then the real esophagus. So once we intubated the real esophagus, basically we went into the stomach. There was a lot of like fluid there, but completely normal stomach. We continue our exam, and as we are advancing into the duodenum, which also looked like the mucosa was pretty normal, we noticed at the very end that there was like this kind of like extrinsic compression of the duodenum as well. So that basically explained, you know, why she was having the symptoms. However, we couldn't tell from this what, you know, what was compressing. Definitely nothing intrinsic. So, you know, when I saw this patient, I started to look up, like, you know, is this something that happened before? Is this common? Actually, Nikhil, I think he had some experience about it. And there are like a number of case reports, mostly like the ENT literature, reporting esophageal perforation from different type of like cervical hardware. There is actually a case report in the ACT case reports journal about it. But most of it is like basically focusing on like the different types of like repairs that ENT and neurosurgical repairs that they don't exist out there. So I'm not gonna focus the conversation today on this particular aspect of the patient. But then, you know, when we start to analyze what is happening in the duodenum, we went back, we took a sagittal view, as Dr. Nagula always recommended, and we found this basically on the CAT scan that she had before the NDQ placement. And as we all know, this is the aorta and this is the SMA. And when we measure the angle between those two arteries, we noticed that the angle was very narrow, around 14 degrees, which is consistent basically with what we call a superior mesenteric artery. So this is what I'm going to talk about today. Of note, the patient had kind of like a significant weight loss over the previous years. She went from 139 pounds to like 86 pounds. That's the weight that they documented a few months before the admission. We don't know exactly how much she was weighing at that time. So basically, the superior mesenteric artery syndrome is a chronic duodenal obstruction from compression of D3. Sorry, I covered that D3 there, between the SMA and the abdominal aorta. In terms of like what's the definition or what is the radiographic criteria to make the diagnosis, basically we need to have an aortomesenteric angle that is less than 25 degrees. The normal is between 35 and 65, and or an aortomesenteric distance between 2 and 8 millimeters. So anything less than 10 is considered abnormal. This is a very rare condition. The incidence varies, but it's like less than 1% in the population. It's more prevalent in female population and younger age, so mostly teenagers, but we can see that in adults as well. And interestingly, the mortality rate is high. 1 in 3 patients with this condition could die. And basically the reason is like usually takes longer for physicians to diagnose. Patients present with like multiple symptoms that I'm gonna describe now. So it's hard to make the diagnosis, and by that time, patients already lost a lot of weight. They have like a lot of electrolyte abnormalities that lead to increased mortality. When we think about the risk factors, like the way to kind of like classify or think about this is like different groups of factors. So the main reason would be significant weight loss. So this is gonna lead to a loss of the mesenteric fat pad, which is the fat between the two arteries. And it's gonna be associated with a decrease in the BMI. And this is, as I mentioned, is one of the most common causes. We see this a lot in patients with eating disorders, burn injuries, or bariatric surgery as well, so rapid weight loss. Then the second group is attributed to like external causes, so usually associated to the spinal or abdominal surgery. So patients who have spinal surgery for scoliosis is one of the common ones. Those were the most common case reports that I saw. And then there is a displace of the origin of the superior mesenteric artery by when you lengthen the spine, basically after the surgery. Interestingly, there were some comments about like patients after having proctocolectomy with the ilioanal pouch for ulcerative colitis, they could have this presentation. So there were a couple of cases also associated with like IBD, not necessarily for IBD related, but like surgery. And then lastly, some congenital abnormalities that could also be present. Patients with like mesenteric, or sorry, with aortic aneurysm also compressing or like narrowing that band. In terms of the diagnosis, like clinical presentation, so patients are going to complain of postprandial epigastric pain, early satiety, nausea, abdominal pain, emesis, and weight loss, as I mentioned. Some patients, would be asymptomatic, and it's going to take a long time for us to actually get into the diagnosis. Potential imaging that we could utilize would be upper GA series with a small bowel follow-through, and we're going to see basically the disruption of the contrast at the level of the duodenum. That's going to raise our suspicion. Ultrasound, actually, they describe is good to kind of like measure the angle. So even a simple ultrasound could be an initial look test. And then CT abdominal pelvis with radical contrast and more specialized imaging we can observe here. We can actually measure very well the angle with MR or CT angiography. EGD is not necessary for the diagnosis, but some of the things that we can see when we do an endoscopy in these patients will be all food in the stomach, duodenal dilatation, desor, and obstruction at the level of D3, which is always. In terms of management, so the main goal for this patient is basically weight gain, because we want to reestablish the fat pad around the arteries. So the first portion is conservative management, so GI decompression, basically like placing an NG tube just to relieve a little bit the symptoms. But the nutritional support by placing patch, mostly like that's a recommendation, but also like nasogastric tubes are described, especially like the pediatric literature. Some patients, they might need parenteral nutrition in addition to the enteral nutrition, because at the beginning they won't tolerate even like the enteral nutrition. These data that I'm adding here is from retrospective study done in China with 26 patients with SMA syndrome, and basically they underwent like different type of enteral nutrition, and for the most part, most of the patients had like around 10 months with whatever device they were utilizing. And they basically demonstrated that there was a significant improvement, not only in the weight and the BMI of these patients, but symptoms score and the fat mass overall. So definitely that's the main treatment for these patients. And then those small number of patients that don't respond to conservative management, so there are different surgical techniques that surgeons can offer. So basically the duodenal jejunostomy is the most used and most recommended. So it's the one that we can see here, and there are different types. One with like a partial resection of the duodenum as well, but also the gastric jejunostomy and the Strong's procedure, basically in which they do a lysis of the ligament of traits, and they kind of like strengthen the angle of the duodenum to try to avoid like that compression in that area. I found only one case report of this endoscopic management. It was very successful. This was, I think, in a patient who was like 84 years old or something like that. This was done in Belgium, and basically they did endoscopic and fluoroscopy guidance. They passed a guide work that was advanced through the string stenosis of the D3, and then they say they reported like an exchange to like a nasobiliary catheter, and then basically they infuse water into the jejunum to kind of dilate the jejunum, and we're gonna see here how we can visualize that in the ultrasound. And lastly, they basically do like electrical therapy enhanced delivery system, and they deploy stent, a metal stent. Can I show some images after that? And that's the end product. And over here we can see the stent. So some of the take-home points: suspect SMA syndrome if there is any evidence of duodenal obstruction, as a history of like significant weight loss. Confirm the diagnosis with imaging, different type of imaging. Basically, we want to make sure we measure the aortomesenteric angle and also the distance between the arteries. The main goal of treatment is weight gain, and then enteral nutrition leads to successful weight gain and symptom improvement in these patients. Back to our patient, so we ended up placing a PEG J on her. She had transcervical removal of the hardware. She had esophageal perforation repair. It was a defect of 4 centimeters. This was a combined surgery done by ENT and neurosurgery. And basically they use like pectoralis majors flap to kind of like cover the defect. She gained weight during the admission, so her last weight a couple of days ago was 92 pounds. At some point during this admission, Rabak saw her. They consulted us for like clogged J-lib of the patch. They ended up removing the patch because she's actually tolerating PO now. She's actually on a regular diet, and she's also tolerating GP feeding. So very successful case. I mean, the patient has all the complications of it.
The G is not clogged.
You gave us the update. Thank you very much.
Any questions? That was a really nice presentation of a fairly rare entity, although our team has seen, I think, 2 or 3 of these last couple
I don't know
months.
why.
I didn't recall this case in percent, and the second I saw that screw, I remembered the case now. But we had actually, oddly enough, like 2 or 3 calls from outside hospitals about this same problem, which is why as soon as we saw it, I just called Eric Gendon because they were calling to see if there was anything we could do endoscopy. But obviously here you have spinal hardware that has eroded into the posterior esophagus. You've now got GI organisms that are getting into what should have been a sterile space. So that was an easy no, but I referred them to Dr. Gendon, who's done a couple of these, he said. So I think the other important point here is, and we talk about it a lot, is to look at your own imaging. We joke around in our team, the sagittal view, we call it the Satishional. Satish always looks at the sagittals and will find things, but I think it highlights you can actually measure that angle and really be able to tell if this is contributing to the patient's symptoms. So really nice case, difficult case, but it sounds like she's getting all the appropriate treatment.
So you do try to remove the hardware.
Don't touch the hardware. No.
Yeah, just leave it alone. Don't pull on the staple. That's what Jerry always said, don't pull the staple.
But I think it helps. It's like the fact that people are thinking, is there anything endoscopically we can do? Just, you know. That's a hard no, though. That would be a very long RCA.
All right, that was a great case. This is going to be a little more basic. Get started. Okay, so we have a 62-year-old male with hypertension, hyperlipidemia, and CAD, referred to the Bronx VA for polyp surveillance. He's asymptomatic, afebrile, hemodynamically stable, unremarkable exam, not on any blood thinners, and he had a prior remote colonoscopy with polyps. So we did his colonoscopy, and we found a 1.5 centimeter polyp in the ascending colon with kind of a short, thick stalk. We removed this block with a hot snare and deployed 1 clip at the base to prevent post-polypectomy bleeding. So we did not have video at the VA, but you can see on the left side there's the polyp. The middle, we're starting to resect it, and then the last photo, we deployed a clip. So a question that my attending posed before we took this polyp out was, should we clip the base or stalk prior to resection to prevent post-polypectomy bleeding? And I know that this has come up a couple of times, and I didn't really know the data on this, so I decided to look this up for Endo Conference. So I just want to talk briefly about prophylactic clipping for prevention of post-polypectomy bleeding. We'll look at this article, prophylactic clip application for large pedunculated polyps before snare polypectomy may decrease immediate post-polypectomy bleeding. So a little bit on the background, the efficacy of prophylactic clip application before polypectomy in large pedunculated polyps is actually controversial. And this study aimed to evaluate this in large pedunculated colon polyps in particular. And so the methods, they had 137 large, which were defined as greater than or equal to 1 centimeter pedunculated polyps in 116 patients that they randomized into group A, which had prophylactic clipping of the stalk, and group B, no clipping, and then resected with hot snare. They measured the occurrence of immediate post-polypectomy bleeding and delayed post-polypectomy bleeding. They defined immediate bleeding as continuous bleeding that lasted greater than or equal to 30 seconds during that index colonoscopy. And then the delayed bleeding was defined as hematochezia from the day of the procedure all the way to the first outpatient GI visit a month later. The demographics, group A, which was the clipping group, had about 67 polyps. Group B, the non-clipping group, had 70 polyps. The median polyp diameter in both groups was about 1.5 centimeters, just like ours. And the median stalk diameter was 3 millimeters. And then their results, they had 28 total immediate post-polypectomy bleed episodes in all 137 polyps. So about 20% of these large colon polyps had immediate bleeding. Only 6 bled in group A, which is the clipping group, and 22 bled in group B, which was the non-clipping group, and this was statistically significant for immediate post-polypectomy bleeding. However, the rate of delayed post-polypectomy bleeding was not significantly different between the two groups, and they noted that there were 5 delayed bleeds in each group, But interestingly, all of group A were all minor bleeds that didn't require repeat colonoscopy or endoscopic intervention. And then 2 in group B required repeat colonoscopy and endoscopic clipping for large bleeds. And then during their analysis, they also found that polyp size greater than or equal to 2 centimeters and stalk diameter greater than or equal to 4 millimeters increased the risk of immediate post-polypectomy bleeding overall. So conclusions from this study: clipping the stalk of large pedunculated colon polyps prior to resection is effective in decreasing immediate post-polypectomy bleeding, but not necessarily delayed bleeding. I will say that a major limitation of the study was it was very underpowered, especially that kind of sub-analysis of the delayed bleeds. So if there were to be a larger study, kind of with more delayed bleeding found, we may see more of a difference. So I just wanted to open it up and see kind of what everyone does. I know we've talked before about endo loops and doing other prophylactic measures and whether or not this is done routinely.
Martin, is that the only study published? Is that the only one in the literature?
This was one of the most recent ones that I found, and one of the only ones looking at colon polyps in particular. I guess, I think I did see some that were like large polyps in the duodenum and things like that, or a little bit smaller, but I'm sure there's more literature out there. I don't know if anyone knows any other studies off the top of their head.
There are other studies comparing mechanical ligation and epinephrine injection, which is another common practice, to no treatment. And kind of similar to what they found, the benefit really is in large polyps. And there is a recommendation in the sort of EMR guidelines to do some sort of mechanical ligation prior to resection of colon polyps that are pedunculated and greater than 2 centimeters. So that is pretty standard practice. I would say we do that as long as it's feasible. And endoloop or clips are both options depending on what you think will fit around the stalk. I usually don't use epi. Mechanical ligation is better. And yeah, it works pretty well.
Just looking at this one, it looked like a very stubby polyp
this was-
stalk. I'm surprised that you would, I'm not sure you would have been able to grab it with a clip.
Yeah, so I was just gonna make that point that with the wider stalks, in our endo unit, we have some wide jaw clips that go up to 17 millimeters of a jaw opening, but sometimes they're not wide enough. So you can either try to stack clips so that they're overlapping, or you can use an endo loop, which our team has used in the past. But the problem is then you're also relying upon the tech to have used an endo loop recently. So oftentimes we'll have to kind of walk them through how to use it. But that sort of functions like an endoscopic zip tie. And when we've done cases like this, when you choke down that zip tie at the base, and you just sit there and just wait, you can actually see the polyp turn, purple and change color because you're decreasing the vascular supply. And then after waiting a minute or two, then you can excise it. But yeah, our group tends to favor more the mechanical options over epi, which, with epi in general, if you're getting sort of a tamponade effect and then maybe some secondary localized vasoconstriction, is very temporary. So yeah, we tend to try to use mechanical practices here for these larger pedunculated stalks.
Yeah, they talked about that too, that they put 2 clips over stalks that were too large. All right, thank you.
All right. Title credit goes to Brian, as usual. This is a 65-year-old who we saw late last year who presented with abdominal pain. She actually had a very long hospitalization. She has Crohn's disease, stricture and penetrating Crohn's, with multiple surgeries. When she came in, she had an SBO and went to the OR multiple times and had a bunch of surgeries done. But bottom line, this was her abdomen, which was like a wound vac that was about the size of her entire abdomen. And that's when we were, and this is how it looked after 3 months of this, having surgery, and we were consulted for uptrending LFTs at this point. So you can see here that like over the course of November, the billy had been going up. So we got an MRCP, and there was actually concern for potential acalculous cholecystitis, but when we talked to IR and surgery about it, they weren't quite convinced that the imaging looked like cholecystitis, and it didn't look terrible to us as well. There was maybe some biliary distension, but no definitive filling defect. So we decided to pursue an ERCP, and when we did that, we saw there was a lot of sludge that we drained out, and we hoped that that would help with the bilirubin going down, or the LFTs going down. So unfortunately, they did not. They continued to go up. So you can see the repeat CT shows a very thick gallbladder wall with some pericholocystic fluid there. So now it looked really more convincingly like cholecystitis. They were not a candidate for surgery, and IR said they could do a PTC. But given her abdomen being wide open, we thought, let's try to not have her have another, drain coming out the side of her abdomen, and let's try internal drainage to alleviate her cholecystitis. Oops. So we went in with our EUS scope, which remembers the side viewing scope. We pop into the bulb. We see the liver, and then you see the gall. Oh my gosh, sorry.
It was a quick procedure.
Yeah, that's how long it takes in real life.
Okay, you see the gallbladder coming into view here. And you can see that it has sludge, this like starry sky appearance, but also like a lot of thick layering sludge at the base. We measure the distance between where a needle will come out and the gallbladder wall here. And then we also measure the gallbladder wall thickness, which is over 3 millimeters, which is abnormal. And then we measure the total diameter of the gallbladder as well, because this is the runway on which the aluminum posing metal stent would be placed. So you can see that we have our needle out here. We check to see that there's no thick vasculature we'll be piercing through. And then using electrocautery, we advance the catheter of the aluminum posing metal stent into the gallbladder. Through this catheter, we thread a wire, and this is just to ensure access into the gallbladder in case there's any maladeployment. We have at least access there, and we can salvage it with another stent. But in any case, you can see the proximal, the distal flange deployed here, and then the second flange we're deploying inside our scope, and then we switch to the endo view, and we kind of push the catheter out, and so that the second flange deploys in the duodenal bulb lumen. And you can see there's this flow of bile and pus coming out there. And we're always doing this while watching the EUS view, endoscopic view, and fluoro. So you can see the stent was deployed there in the fluoro. So over the wire that's through the stent, we then dilate the waist of the aluminum posing metal stent open to facilitate more drainage. You can see we advance the dilating stent there, and then we inflate the balloon. So doing this under fluoro and endo view as well. And so you see a lot of fluid coming out, and then you still have that wire through the stent, and over that wire we put a coaxial double pigtail plastic stent, and this is so that when the gallbladder wall or the gallbladder collapses, with all the fluid coming out, the back part of the gallbladder wall doesn't rub up against the metal stent to cause bleeding and things like that. The plastic stent kind of keeps that wall away to prevent any delayed bleeding complications. So today I'll be discussing one of two non-endoscopic therapies for endoscopic gallbladder drainage. So there are basically three non-surgical therapies for gallbladder drainage. There's the percutaneous approach. There's transpapillary endoscopic gallbladder drainage, where you put a stent from the gallbladder through the cystic duct into the duodenum. And I hope to present this next week if we get our patient to get this today. And then the one that we just showed is the EUS gallbladder drainage method, where you have from the duodenal bulb or even the stomach, wherever you can see the gallbladder, you put aluminum posing metal stent so that fluid and stones can drain out. So again, just looking at the procedure itself, you can see our scope was parked in the bulb. We used the catheter to, pierce across the wall, and then deployed the flanges so you see this the stent in place there. But essentially, this is making a transmural puncture of the gallbladder. So you want the patient to not have ascites. You don't want the gallbladder to be floating away. You want the coagulation, the INR platelets to be normal, because you are, making a hole in two organs. And then you also want to make sure that the patient doesn't have a gallbladder perforation or any sort of biliary peritonitis, because that would be a case where we don't want to be insufflating air and scoping and creating, more holes. That would be more appropriate for interventional radiology. Another thing to consider is sedation when considering your gallbladder drainage like this. This does generally, we like to intubate these patients because there can be a gush of fluid that comes out of the gallbladder. And so if the patient can't really tolerate general anesthesia, and they might benefit from a perc drain because they could get that done with local anesthesia and minimal sedation. Again, main thing though is that you're creating a fistula between the gallbladder and the duodenum. And so one of the things that you have to assess is that are they a surgical candidate? Because if they are a surgical candidate, you want to discuss that with your surgeon before you do the procedure. It would make the surgery after to remove the gallbladder difficult because the duodenum and gallbladder would be scarred together even if you do remove the stent. So that's surgical consideration really is how we determine which method we take in picking gallbladder drainage. So if they're a surgical candidate, definitive therapy is laparoscopic cholecystectomy or some sort of cholecystectomy. If they're never going to be a surgical candidate, then EUS guided gallbladder drainage is appealing because it provides a good luminal diameter for the pus and bile and stones to flow out compared to the endoscopic transpapillary drainage, because that you're just propping open the cystic duct in order to alleviate the cystic duct obstruction causing the cholecystitis. But if they're not a surgical candidate now, you just want them to cool off, and they will be a surgical candidate, or if they're going to go for liver transplant or something else where they need to preserve the vasculature and integrity of that area, you may not want to do the endoscopic gallbladder drainage. Those patients you might favor the percutaneous approach versus the transpapillary stent approach, and we'll talk about that more later. So coming back to our patient, the two things we were considering were IR drainage versus EUS guided gallbladder drainage. So I wanted to discuss this study that compared both those methods and talked about the clinical and technical success of doing both. So this was a multi-center study. It was retrospective in nature that was spanned over 7 institutions. And they looked at 45 patients who underwent EUS gallbladder drainage and 45 patients who underwent a percutaneous cholecystostomy. And they looked at the technical and clinical success. And you can see that from the procedure details, one point to make is that a lot of them used cold lumina-posing metal stent placement, which means that if you remember, we had that sizzle of piercing the gallbladder with electrocautery that makes it much easier to actually deploy the axial stent. Versus cold is a little more challenging. You have to use balloons, cystotomes, needle knives, things that I haven't actually used, but I know Nikhil can describe that. But the bottom line is that when they did the subgroup analysis between the non-cautery enhanced lambs and the cautery enhanced lambs, there was no difference in the clinical success, technical success, or adverse outcomes. Then going to the procedural details between the EUS guided gallbladder drainage and PERC approach, the gallbladder drainage group, mostly all of them had general anesthesia compared to the PERC group that very minimal had general anesthesia. And then the procedure time was slightly longer with the EUS based approach, but the median time was like a difference of 6 minutes, so it's not that big a deal. And then the main things here that both had very similar technical success, meaning that they were able to do the procedure they intended successfully, and clinical success, meaning that labs, radiology findings, and the patient's clinical picture improved in 3 days. They both had very similar outcomes in relation to that. But the EUS gallbladder approach, the patients had much less pain because it's all internal on post-op day 1. They were in the hospital for many, like only 3 days compared to 9 days, so fewer days in total. And then fewer of them needed reintervention because, as you know, if they get a drain, then they have to go back to IR for upsizing the drain's clogged, or they have to have the drain removed at some point. So for all these reasons, the US guided gallbladder drainage group seemed to have better outcomes. So the take-home points here are that you should always, before you offer this, you should always check the surgical candidacy of the patient with the surgeon, because if they would be a candidate, you may not want to alter the anatomy in that area because of the scarring there will be from the gallbladder to the duodenal wall. Check the patient's ability to tolerate anesthesia. They will need like deeper sedation, obviously, for doing endoscopy, versus the percutaneous approach can just be done with local anesthesia and minimal sedation. And then stay tuned for the endoscopic transpapillary drainage approach. But before I finish, I wanted to follow up on this patient, if you remember, who had this big 2 centimeter, 3 centimeter hole in their esophagus where we did a mediastinoscopy essentially. That patient's stent slipped. And so we went back to retrieve the stent, and then we saw that the entire esophagus was scarred down and there was no hole. And this is like 4 weeks after. So you can see the stent that is in the stomach that we couldn't retrieve because this is so narrow, but then we actually had to re-stent the area to hold the lumen open, maintain luminal patency. But I thought it was really impressive that this hole actually closed. So,
Questions, comments about the gallbladder drainage or the Borhaus case that? Yeah, so it's a really nice option for gallbladder drainage for these non-surgical patients. I mean, you showed a picture of what her belly looked like. It was really not a good option for percutaneous drainage. And if you go back to the study that you showed, they actually did more IR reinterventions than actual original procedures. Yeah. So patients don't like those tubes. If they're not sort of fully copious mentions, they can pull out these tubes and get dislodged, and you run into a lot of problems. So internal drainage here is a really nice option for this patient, but really important that you have multidisciplinary conversations with the surgical team and sometimes IR as well. You mentioned putting the pigtail in through the lumen-opposing metal stent. In my mind, it serves 2 purposes. One, when that gallbladder decompresses, you don't have the friction against just the metal stent, so it creates somewhat of a buffer using the pigtail, but also anecdotally, before we didn't put pigtails in, sometimes food would get clogged in the stent or go into the gallbladder. And so I think having a pigtail stent through the lumen also sometimes prevents some occlusion from
what's
food.
interesting is in this study, like it was not many people actually use the pigtail.
Yeah,
it seems to be a preference.
Yeah, I think that's an endoscopy preference, but I found it to work. And when we used to do the cold, that was very painful. It was very sort of Seldinger technique where stick the gallbladder with an EUS needle, coil a wire in the gallbladder, then leave the wire in place and take the needle out over the guide wire, and then we would have to use like a needle knife or a dilating balloon over the guide wire, open the tract, and then go with the cold access. So this has made it so much easier with the electrocautery enhancement.
Yeah, definitely.
Question, wonderful presentation, by the way, and very well organized. Long term, I know these are pretty hopeless cases, and I know we don't use that term very often. You're putting all this hardware into an area that is already prone to infection. Do we have any data on 3 months, 6 months? What happens to these
There
patients?
is actually long-term data that suggests, compared to percutaneous cholecystectomy, the rate of recurrence of cholecystitis is less in the US gallbladder drainage group. Usually, long-term, if you are going to keep this and they're not like terminal, then you can go in and remove the axios and just put double pigtails in there just to maintain that patency, versus the perc drains, if they're going to live a long time, that perc drain is going to come out, so that the patient will perhaps have recurrent cholecystitis because they won't have drainage of that gallbladder. So this kind of maintains more long-term or durable drainage of the gallbladder, so there's less recurrence in this.
It's not clear what we do afterwards. It's, again, dealer's choice. So some people leave it in there indefinitely. Some people have a protocol where they take it out after a couple of months after re-imaging them, either put pigtail stents in or just take it out and let it seal off, depending on if you go in there, take out the stillage or not. So we don't know yet. It's just a new technology that's coming out. And so we're learning long-term data. But the longest in case reports has been about 3 years. And patients do okay. So we don't know. But the whole point is that it gives you a lot of options for something that is pretty common of a problem, and percutaneous drains, everybody knows hates. So it just widens your variety of treatment options.
Yeah, we submitted a paper with our long-term data, so it's in review right now.
So as more of these studies come out showing not only like technical equivalence, but potentially superiority in some aspects, especially like the long-term data and the reinterventions, like, do you think that this is going to be the primary method of non-surgical gallbladder drainage?
It depends about if there's gonna be a surgical
be
method
MRSA.
though, right? Because the main benefit of the perc chole is that you're maintaining the anatomy of that region so that they can go back to getting their gallbladder removed, which is a definitive management. But yeah, for a patient who's never gonna be an operative candidate, this is probably superior to the perc chole for patient comfort and for recurrence rates. I don't know if it'll take over perc choles because it seems like a lot of people just need to cool off before they can get their gallbladder out. And that really is better served with the perc chole since it doesn't make it hard for the surgeon to remove.
All right, it was a great conference. Why don't we stop there? We'll give time for our great non-speaker to get.